I'll be talking about the ideal organizational staffing. I'm sure all of you would agree with this point that the success of an organization depends upon the efficiency and productivity, which is definitely influenced by the organizational structure. When we talk about the organizational structure, we talk about the divisions of the departments, it would outline the functions of the department, the tasks performed in the department, and also provide the line of command, that is the reporting authorities, and the communications, as well as define the protocols which is put in place. So organizational structure should enhance and not impede with the progress of the process. We'll talk a little more about this a little later. Now, what are the cadres of staff that we have? This is, I think, common to all the organizations across the country. We have medical officers, which is the ophthalmologists. We have fellows who undergo fellowship, residents, DOMS, dependee. And then we do have a new category, the MLOP employees and the trainees. Yeah, I just wanted you to look at the MLOP category. I would be talking about it a little more. Now, as far as the hierarchy goes, each center would have probably a director or a chief medical officer. They would have department heads, an administrative officer who need not necessarily be an administrator. He could be a physician who is interested in performing the administrative tasks. Now, the structure would be based on grouping of the tasks. Staff should not be performing tasks below their level. That is, I wouldn't, as an ophthalmologist, want to be performing vision testing. So the nature and the level of task should match with the capacities. And coordination is through supervision, which has been very nicely outlined in that couplet which Thiruvalluvar had proposed many centuries ago. So you all agree that ophthalmologist time is the most expensive and the most scarce resource in the country. Now, so to increase the overall productivity, ophthalmologists should spend time only on those aspects of diagnosis, treatment, which they have been trained for. So we know that productivity is from proper utilization of the resources. So highly trained paramedics. Now I'm introducing this paramedics because that's a terminology with which we're all very familiar with. Paramedics can handle the routine tests and measurements. The result again is a high throughput, better quality, and the patients also have a better experience. Now I spoke about the term MLOP. MLOP is a mid-level ophthalmic personnel who works under the supervision of an ophthalmologist who performs repetitive tasks. Now, who are these people? These are non-doctors. They're skilled support staff, not independent decision makers, and they often form the main workforce in the hospital setting. The last statement which I made is the statement made out of experience at Aravind Eye Hospital. So what all areas can we use these MLOPs, that is the mid-level ophthalmic personnel? We can use them in the outpatient area, inpatient, operation theatre, refraction, counseling, and optical technicians and medical records. This ensures quality in the outcomes. This ensures patient satisfaction, and there's also equity in care. Now you would wonder how a patient satisfaction can be achieved through a category who is not a doctor. See, as far as, let's take the example of a cataract surgery. Now a patient comes to us and there are a series of tests that needs to be done. When somebody is trained to do these tests perfectly well, I would assume that we would encourage this group to perform all those tests. And finally, coming to the aspect of counseling, this group forms a great boon. It could be a staff, it could be any category, but the task counseling should be done by a non-doctor. In the sense, can be done by a non-doctor. In the sense, any patient who is wanting to undergo a cataract surgery would have umpteen number of doubts, clarifications, and would have a lot of uh, aspects where they would like some help in terms of what kind of a lens to be taken, what kind of surgery would be helpful. All of those things which the counselors are very familiar, probably the type of lens material that is being used, what's the advantage of one over the other. I'm sure in a setup where we are working under the circumstances, given the schedule that we have, we would not be able to concentrate on all of these aspects. So it will be better to have somebody who is well versed with this kind of situation to deliver this kind of service to the patients. So we could concentrate better on providing a quality surgery and also providing a better medical treatment. Now, the repetitive, again and again I emphasize, the repetitive skills have to be delegated to MLOPs. And the administrative tasks can be delegated to the administrators. Again, these administrators could be doctors or non-doctors, depending upon the organization where we work. And this would definitely allow the physician to concentrate on the clinical aspect, thereby improving the efficiency and productivity. Now, this is a very important slide that's been shown time immemorial. In the sense, this slide was made when we started off with EZCs, extracapsular cataract surgeries. And this holds good today even for phaco surgeries. In the sense, a surgeon is able to perform better with 2 scrub nurses. The output is definitely 4 times more than what it is when you have the advantage of somebody assisting you who are non-doctors. Now again, where all can we use? Patient evaluation, monitoring. You can ask the MLOPs to administer drugs and monitor them over the day, diagnostic tests, surgical assistance, counseling, and of course, providing proper direction and referral. Thereby allowing the surgeon to do more surgery, improve the quality of the clinical services that's provided. And of course, a lot of times we keep telling that there is not adequate time to train our postgraduates or fellows. With all these having been delegated to the MLOPs, probably we'll have adequate time to concentrate on all of these aspects. And the one other important aspect which I like to emphasize is the ideal ratio. It's been tested and it has been proven across the country in many of the centers that it would be ideal to have 4 MLOPs per surgeon or per ophthalmologist. And I was not there for all the presentations yesterday, but I come to understand that this kind of a ratio has not been present in most of the centers, which could be probably the way we think or the mindset that we have, that the allocation is not being done, that is these repetitive tasks are not being allocated to the MLOPs. So we have a structure which is, there is an MLOP in charge who is an ophthalmologist, and all of the centers have an MLOP in charge who is not just doing the MLOP work. The MLOP in charge doctor, in addition to their routine clinical services, would also provide assistance in running the MLOP services. There would be a nursing superintendent, and of course a person who is interested in academics would act as the academic coordinator. So it could be one person in the organization who would be interested in providing the academic services. And then we have the different departments who would have an in charge, overall in charge, and who would have supervisors under them who would supervise. And as I already mentioned, we have a vertical line organization where the reporting authority is very, very clear, as well as the job descriptions are made very clear. There is a perfect role clarity for each of the members in the organization. And that would be an ideal situation because there would be no crossovers or crossing the boundaries. And under each category, we would have, like for example, we would have a theater in charge. There would be theater supervisors for each of the theater because you would have several theaters functioning. And there would be senior workers, junior workers, and trainees. And at Aravind, we have a ratio which we kind of stringently follow, where we would have a 50% employee and a 50% trainee ratio. Again, here I would again overemphasize that we need to have a perfect role clarity for every category and also give them a proper job description which would look at the depth of the work they do as well as also give them their limitations. They should not cross over beyond that particular limit. And again, some people we constantly hear this statement that it's possible at Aravind, but it's not been possible elsewhere. But we have tried this model elsewhere and it's been quite successful in Malawi, Egypt, Kenya, Bolivia, and Bangladesh. And I'd like to make a little more emphasis on Bangladesh because Bangladesh has been one big challenge for all of us. When we started off introducing this program in Bangladesh, there was a lot of resistance because in Bangladesh, the doctors never believed in allocating or delegating jobs to the MLOPs. But then once the system was put in place, once the hospital has started running, the acceptance has been multifold and a lot of other hospitals have, in fact, are willing to take in more and more MLOPs now. So in our mind, earlier we used to think geography, yes, has a role in the success of the model. But Bangladesh has proven that the success, it has no influence, the geography has no influence over the success of this model, as well as the cultural variations. A lot of times we say, oh, the culture in South is very different from the culture in the North, but then it has broken all those myths, and I think the models which we have currently in the country prove that there is no cultural barrier too. It's only that we need to have a shift in the mindset at the moment. So I'll just show you an example of a hospital, Aravind Eye Hospital, Tirunelveli, which has an OPD of this magnitude, and the number of surgeries provided are so many. So I just want you to concentrate on the manpower aspect. So if you look at the doctors, there are about 59 doctors, and if you look at the MLOPs, we have about 300 and odd, which is exactly about 4 times the number of the doctors. And the activities, as I had already listed out, we have this many activities which are going on. Yeah, I just want to show the OP now. This is the OPD. This is the, yeah, we have about 240,000 OPD and about total of about, yeah, and this would be about 37,000 and odd, and we have all these services provided too, in addition to the other services which outpatient and inpatient services. And this is the kind of manpower ratio that we have. That is, we have 25 medical officers who are trained and 34 postgraduates and fellows. What I'd like to look at is the number of MLOPs, that is 322, which is about 4 times the number of doctors. Almost 5 times. Yeah, a little more than 5. But then I'm also looking at the other services that we offer also. We have other support services like the instrument maintenance and other areas, housekeeping and all of those areas too. So just like to end this by saying that empowered organization is one in which individuals have the knowledge, skills, desire and opportunity to personally proceed in a way that leads to collective organizational success. I think it's one thing which we have learned in our course of providing this kind of MLOP services. It will be ideal to have somebody trained doing the particular specific job. For example, refraction. I know there are many people who would raise their eyebrows about letting our MLOPs do these tasks. But to me, I think if you have somebody who's been very well trained And if you let them do the job, I think nothing like it. And especially, I would anytime vouch for the MLOPs performing tasks like uh, the sterilization and the OT, where you need not worry about any aspect of sterilization. And in fact, most of us go to a refractionist, that is the MLOP in charge for refraction, for our own refractions. I would rather have it from them than have it from a doctor who's very occasionally doing it. Thank you very much.